So the emergence of this lung disease indeed coincided with the introduction of IL-1 and IL-6 inhibiting biologics, and certainly the thought that these biologics potentially might contribute to its development often keeps me awake at night. And there are certainly many plausible explanations of why it might be happening, and I hope we will have a productive discussion later today about these possible explanations. But even if it is a contributing factor, I do not think it's the only culprit, and we still need to consider other possibilities. And that's the reason I think these two cases that were presented at the press meeting earlier this year are very, very relevant to our discussion. And I hope that the managing physicians of these patients are on the call with us today, and they
are. Sue, do you mind just turning on your video so that we can spotlight you? And yes, Sue is on the call.
Excellent. So if I'm misinterpreting your slides, please correct me. So this particular patient is now an 11-year-old Malay boy from an interior part of Borneo Island. Approximately at the age of 2 years, he presented with prolonged daily fevers, typical evanescent rash, polyarthritis, hepatomegaly, pericardial effusion, highly increased inflammatory markers, and pancytopenia. He was eventually diagnosed with systemic juvenile idiopathic arthritis complicated by MAS. And the initial treatment included IV steroid pulses as well as etoposide. And subsequently, the treatment was changed to oral prednisolone and subcutaneous methotrexate. He was again seen at the age of 6 years. His disease was controlled a bit better on subcutaneous methotrexate, but certainly he remained steroid dependent. And for the first time, he was noted to have erythematous digital clubbing. But at that time, the parents declined further investigations. He was again seen at the age of 8 years. Again, at that time, he presented with another flare of systemic juvenile idiopathic arthritis with both systemic features and arthritis. And also he, at that time, diagnosed with hypertrophic pulmonary osteoarthropathy. His high-resolution chest CT scan at that time revealed diffuse interstitial thickening in both lungs with bilateral pleural thickening and essentially no focal lung lesions. His treatment at that time was changed to prednisolone, hydroxychloroquine, azathioprine, although azathioprine was stopped due to increased liver enzymes. And subsequently, this drug was replaced with MMF. Again, seen in the same center at the age of 9 years, clearly very impressively cushion-guide, and he was not growing at that time. It was actually the major concern for the parents. No fevers, no apparent respiratory symptoms. Did have active polyarthritis on exam, significant digital clubbing. His lung exam, however, physical exam was perfectly normal, and the repeat high-resolution chest CT showed actually very, very similar findings of diffuse interstitial thickening with fibrosis, subpleural fibrosis, but in no new areas affected. And his lung function test at that time was normal, and the treatment included IV solomedrol pulses, joint injections, and he was continued on MMF. The last visit was not long ago. He was 11 years old at that time, remained steroid dependent, still running intermittent flares of systemic JIA with fevers, polyarthritis, highly increased inflammatory markers. His high-resolution chest CT findings remain unchanged. His PFTs are normal, and the most recent echo did not reveal pulmonary hypertension. The team did consider restarting methotrexate for the joint disease. However, the respiratory team in this case was actually concerned about the possibility of methotrexate-induced lung disease and declined. So at the moment, tocilizumab or cyclophosphamide are considered as possible additional therapeutic agents. And Dr. Sueng posed these very, very reasonable questions that I hope we will be able to address later in the discussion. So any other important points that I missed in your slides?
I think you got mainly the gist of it, but I think just one correction. He didn't have erythematous digital clubbing. Of course, the initial presentation, he was heavily managed by the infectious disease team. We only managed to see him with our first rheumatology consult when he was about 7 years after his first diagnosis. Yes.
But anyway, the point basically, when I look at the description of the chest CT findings, to me, it does sound like the disease that we are seeing here in the States. And again, that occurred in the absence of any kind of biologics. Another interesting case came from India. And again, I hope the physicians are with us so they would help me to go through the slide. So this particular boy is now 8 years old. He initially developed the first symptoms of systemic JIA at the age of 5 years and 5 months. He presented with pretty impressive polyarthritis, fevers, typical rashes, hepatosplenomegaly, pleural effusion, and also had some muscle weakness during the course of the disease. And I believe some dyspnea was noted clinically early in the course of the disease. The other interesting feature in this case was recurrent episodes of MAS. And if you look at this part of the slide, the doctor summarized the laboratory features prior to the initiation of the treatment. And you can see high levels of ferritin, highly increased levels of IL-6. So he did have a little bit of muscle weakness. And interestingly, this patient did have JO1 antibodies. And I think it's sort of a strange feature that potentially we could discuss later. But again, I would like to draw your attention to the description of the chest CT findings in this particular kid. Intra and interlobular septal thickening in both lungs, minimal to mild increase in the parenchymal density in interstitial thickening with ground glass density in the anterior aspect of the left upper lobe and lower subpleural aspect of the right middle lobe. To me, it sounds like again, the classic chest CT picture that we see in patients with lung disease in Cincinnati. Clinically, he was not doing that great, and certainly progressive worsening with pronounced reduction of diffusion capacity was observed during the course of the disease. And again, coming up to this unusual feature of muscle weakness, the MRI study did show some inflammatory myositis. So initially, this patient was treated with methotrexate, cyclosporin, and MMF. And again, he developed this lung disease while being treated with these medications. And it looks like tocilizumab was started relatively late in January 2020. And sort of the last thing I heard about this kid, he was improving a bit. So again, another case, we certainly see this sort of very, very characteristic pattern, chest CT pattern that occurred while this patient was treated with non-biologic disease-modifying drugs. So again, sort of, to me, I do agree that we need to consider the possibility of biologics contributing to this disease, but I don't think it's the only reason. There are some others, and we need to consider those possibilities as well. I'm asking the physicians who took care of this kid, any other additions, any other corrections?
No corrections at all. I think, Alexei, you've captured the entire essence. And in fact, when we started reading the early reports and when people started talking about the fact that biologics are responsible, we were rather thinking of quickly writing a letter to the editor saying that our kids, we have one more patient with similar features, have actually not taken any biologics before the onset of this entire story.
Thank you. Thank you, Rashmi. That was my last slide.
Okay. We'll move on next. Sheila, are you there? Yeah, there you are. So I'm going to quickly talk to Sheila Simon. This is, of course, a topic of quite discussion in our group. And I'm going to talk to Sheila and then invite a few of the other patients to quickly share their experience. And Sheila and any other patients, I'm going to ask us all to be succinct and to really focus on the events rather than anything else. Okay, Sheila, do you want to quickly describe your child's journey starting from the diagnosis?
Sure. Hi, everyone. I'm Sheila. My daughter's name is Alyssa. She is now 9. She was diagnosed 2 years ago at Lurie's Children's in Chicago. Considering she was diagnosed really quickly, 29 days from start to finish, she had hives, fevers, and lymph node involvement and was admitted initially the first day for 11 days for viral pneumonia. They ran every infectious test, all negative. And all her labs started dropping on day 11, so they sent her home. Classic. And then 2.5 days later, her pediatrician sent her back because she had nonstop fevers, full body hives, extremely lethargic. Like my daughter can run miles and couldn't even walk to the bathroom. Was sent back. So I did not realize she was swollen all over her body and had bruises around her knees. And the ER doctor ran her ferritin and it came back at 58,620. Initially diagnosed her with HLH and started IV steroids immediately. A little bit of an ER emergency, she called it, a little bit. And hours later, they started IV cyclosporine. And 2.5 days, she had to start antihistamines, 3 different ones because of her full body hives were extremely itchy. Drove her insane. 2.5 days later, they stopped the IV steroids and added anakinra 2 times a day. Fevers immediately stopped, and ferritin flew down by day 4 to 4,700. She still was having full body hives, and they noticed her eosinophils were astronomically high. So that's when they stopped anakinra because they believed she was allergic to it, and brought in hematology and oncology. And they requested a bone marrow biopsy and a full PET scan to rule out lymphoma, leukemia, everything else. And let's see. As soon as they stopped, though, her fevers immediately came rushing back. And we're done. So on 2 days without anakinra, they changed of rooms again, and a new room came, and said she was not allergic to anakinra and put her back on anakinra. Again, still had extremely high eosinophils and the extremely itchy hives. Her bone marrow biopsy came back and said she has no leukemia, low lymphoma, but has eosinophilia. So she stayed on anakinra while she was in the hospital, and day 26 of the whole hospital stay, they ended up discharging her, still only on 2 antihistamines, and moved to Kineret once a day. And her ferritin was down to 1,000 and still covered in full body hives and eczema. Her IL-18 came back. It was 321,618. And that's when she was diagnosed with systemic J mass, finally. And she stayed on anakinra, saw her rheumatologist, and still had on and off hives. And she reached stable labs within 2.5 months. And she was, because of the hives, they offered to switch her to Alaris a bunch of times, more than once. And because the group is wonderful, and Long talks about how medicines possibly might not work again or might not work if you switch, we decided, because anakinra was actually holding back all her systemic J fevers, except she only had a systemic J rash 1 time for like 2 days at the most. And that's why they said she never fit, because she never had arthritis or any joint pain involved. So we decided to stay on it because you don't mess with what's working. And she was able to slowly wean off Kineret at 19.5 months. And she was off of cyclosporine she was only on it for 8 months. And she was able to wean off, and we've been off for 5 months.
And how is your child doing now?
She is doing amazing. You cannot tell she has anything wrong with her, other than she's a little bit more tired when it comes to long, strenuous activities. Before, she would be able to hike for hours and ride her bike for hours. Now she needs breaks, and she never needed breaks before.
Okay, thank you. Thank you, Sheila. Any quick questions from the doctors? Okay, so I'm going to quickly ask one or two other patients, not in depth, but just quickly in a minute. Who's there? Regina, are you there?
Yes, good morning, Rashmi.
Regina, can you just share your recent experience with a reaction?
Sure. So I will just say that Juliana has tried Kineret. She was fairly controlled with that for about 2.5 years. But we had to keep on increasing her dose for such a small child. At one point at home, she was up to 300 milligrams daily. And it was a challenge, and my insurance company just said, enough, let's move on and try something else. So we switched over to subcutaneous Actemra this past February. She had seemed to respond fairly well, but we're not really sure because she was also on high dose steroids at the time. Come July, either she started flaring or Actemra sub-Q started losing its effects. So we decided to change over to IV tocilizumab. And I had some reservations because, you do hear about adverse reactions. So she started her first Actemra injection on August 31st of this year. And it went okay. About 24 hours later, she was covered in hives. Her eyelids were thick and she said she was itchy. So I gave her some Benadryl, reported back to the physician, and we continued for 4 more IV infusions. She had no adverse reaction during the infusion itself. She was monitored at the center, as they all are. But on the 5th infusion on Columbus Day, we did the pre-med, we did the Solumedrol prior, and we hooked up the tocilizumab. She had 3 cc's, and immediately, I looked over to the corner of my eye and she was tomato red and was coughing, like excessively coughing. So I called in the nurse, and they believed she was having some sort of adverse reaction. So we immediately stopped it. But my daughter had diagnosed lung disease way prior to ever starting tocilizumab. The only biologic she had been on was Actemra, anakinra. And now that we've tried those 2, we are trying Alaris. So yeah, that's a little bit about our adverse reactions. So it's just diligence and monitoring and, keeping an eye on everything. Even right now, as we're switching, I'm keeping an eye on her and documenting everything.